Welcome to our annual Neuroscience Conference. I'm Mandy Binning, along with Greenberg and Natalie Gofman. And today we want to talk about alteplase and thrombectomy complications, prevention, and management. The next slide, you can see the objectives. Then we're going to just get right into talking about some cases. So, Dr. Greenberg.
Thanks, Mandy.
Yeah.
So for those of you guys who don't know who we are, Dr. Binning is one of our top neurosurgeons and director of a stroke program. I'm the director of our neurologic emergency department, which is the only neurologic emergency department in the country. And Natalie is our amazing neuropharmacist who already got a shout out from Dr. Vez this morning. She is such a great asset to everything that we do here at GNI. So we are the ladies of GNI for your expert panel here for the next hour. And we're going to talk to you guys about a really hot topic. We're going to talk about alteplase and thrombectomy. What are the managements and what are the complications of the things that we do every day? And so the first thing that we want to talk about is acute ischemic stroke. And we actually do a really poor job here in the United States of treating acute ischemic stroke. There's only about 5% of all patients across the country that get treated with IV alteplase. And the reason for that is because that does include patients who have contraindications. So they're on blood thinners, or they've had a recent stroke, or they have a hemorrhage, but we really are not capturing a lot of the patients that need to be treated. The exclusion criteria that we use at Crozier are actually pretty extensive. For all of my ER companions that are out there, there's really no other drug in emergency medicine, or I think in neurosurgery or in pharmacy, that comes with a contraindication checklist that has 20 bullet points on it. So it does need to be respected. Why does it have 20 contraindications that we go through? Because the dreaded complication is bleeding. Right? Yeah. And bleeding specifically in the brain. We quote patients a 6% chance of intracranial hemorrhage. That goes all the way back to the NINJ trial in 1995. What we know in 2020 is, if you agree at all the spokes that you're at, really the rate's 2 to 3%.
Yes, it's low. And all of this exclusion criteria has actually been narrowed significantly to you have absolute exclusion, and then you have sort of these relative exclusions. And for the most part, unless there's something really off with those relative exclusion criteria, we're giving the alteplase to those patients if their deficit warrants it.
Right. And I think that part of the reason why we consider that too is a big thing in emergency medicine is a lot of people don't understand that most of the lawsuits are for not giving alteplase rather than giving it. Yeah. And having a potential bad outcome.
Especially because most of the time the deficits is what causes extended length of stay. It's going to cause more need for rehab, and it's going to have the patient have those deficits for the rest of their life. And that's where we really need to make the decision. Do we give something that's very much life-saving and something that's going to help the patient have a better outcome and a better quality of life versus having an increased risk of bleeding that is actually not as significant as we once thought it was?
Exactly, and I think that the needle has moved to where we used to find excuses not to give it, but now we're really looking for every reason to give it. And so, it's no longer, their symptoms are getting better, or, the deficit's not that severe, but you can have aphasia, and that's a very severe deficit, even though on the NIH scale it's very low. Or you could have ataxia, and your NIH score might be 0, but you can't get out of bed and walk. So I think we're really paying a lot more attention to what that deficit means for the patient than just a number.
And that's actually what I lecture about quite often, and listening to Randy and Danielle's and Ellie's talk this morning is don't get hung up on the number of the stroke scale, get hung up on what the disability is for the patient. You mentioned life-saving, but more importantly, it can be disability-saving.
Yes, absolutely.
So we're going to take you guys through some cases, and all of the cases that we present are real cases that we live day in and day out. So the first one is a 57-year-old male who was found at work 30 minutes prior to arrival with a right facial droop and unable to speak. He was called a pre-hospital stroke alert and arrived at 4:32 in the afternoon. He had a right facial droop. He had a complete expressive aphasia, so this case was actually really difficult because you could not communicate with him at all. He had some dysarthric speech, so thanks to Randy and Danielle and Ellie, we know the difference between dysarthria and aphasia. Yeah. He didn't have any deficits with his strength. He had 5 out of 5 strength in all of his limbs, no ataxia, normal sensation, normal gaze. So he did not have a receptive aphasia. He could actually follow my commands, but he just couldn't communicate at all. So we were really guessing with him, what is this gentleman's past medical history? What are the medications is he on? We always say that the only lab that you need to treat a stroke patient is a glucose. But what if this is the one case where he's on Coumadin?
Yeah.
What if this is the one case where he is on Eliquis, Xarelto, Pradaxa, and he's taken it within 24 hours? So he's presenting some challenges already. And then just for extra fun and challenge, his blood pressure is 191 over 109. The rest of his vital signs look pretty stable. There's no other obvious contraindication to alteplase. His glucose is within normal limits. I like when my patients weigh more than 100 kilograms because it makes my math
easy.
You don't need to calculate a lot.
Yes. So the max dose of alteplase is 90 milligrams. It's 0.9 mg per kg, max 90. So when you weigh more than 100 kilograms, that's one less step that I have to do among the other 50 things that I'm doing in 12 minutes or less in the ER. And his stroke scale is an 8. And what's interesting here, the NIH stroke scale of 8, you think to yourself, wow, how does this guy get to a stroke scale of 8 just for some language problems and a right facial droop? And one of the other things about the NIH stroke scale is it's very heavily weighted towards a left hemispheric stroke that gives you right-sided deficits but language problems, as opposed to a right hemispheric stroke that would just give you neglect and give you 2 points. So our question for you guys out there is, is he an alteplase candidate at this point?
So, I don't, and even the guidelines will say, unless you have reason to believe the patient is anticoagulated, a pharmacy record or family providing history that the patient's anticoagulated, you don't have to wait necessarily to get that information. You give alteplase, and then if you find out later they are anticoagulated, you halt the infusion. So I don't consider that a contraindication. I think really what we're looking at right now is blood pressure control.
Absolutely. And, that's just like you said, Dr. Binning, I mean, it's almost guilty until proven innocent. So, or innocent until proven guilty. Yeah. So this patient is someone that we would absolutely say that we need to start working them up for alteplase right away. The biggest halt here is his blood pressure. So I'm not sure if we've gotten any responses yet, but this patient's blood pressure is above the threshold of where we would be comfortable giving alteplase. So that doesn't mean that we have to, we say that the alteplase is contraindicated. What it means is that we have to treat the blood pressure to make the patient be eligible for alteplase. And that's very aggressive treatment to make sure that they now fall into the guidelines. Because as we said, we want to make sure that he does not have a deficit or a rehab potential that is there for him to be able to recover from this stroke. And we don't want to commit him to any kind of deficits just because of blood pressure. So the way that we usually treat it is we give pushes initially, because we'll know if a patient is going to respond almost instantaneously if we start with something as simple as a labetalol or hydralazine push. It's given rapid IV push, and the blood pressure should respond right away. The only times, and Dr. Greenberg, tell me if you do something different, but the only times that I really say go straight to an infusion is if their blood pressure is significantly elevated, where you know that at 250 systolic, that
Exactly.
10 milligrams of labetalol is not going to do anything for them.
Like spitting in the ocean.
Exactly. But
Just
other than
I
that,
just want to be a little precise. Our blood pressure goal is less than 185 over 110 to administer the alteplase. So if you can get the blood pressure down below that threshold, that's great. But I think the important note is, as the tPA or alteplase is being mixed, just recheck the pressure, make sure it hasn't bounced back above that threshold before actually pushing it.
Yeah, and I think that this is one of the caveats for ER providers across the country is they get hung up on a blood pressure greater than 185 over 110. And Dr. Binning and I both lecture nationally about this. You know, it's kind of my opinion in 2020 that you're a wimp if you can't get a blood pressure down to less than 185 over 110 between labetalol, hydralazine, and now cardine and Cleverprex that we have.
And it's not normotensive. We're still keeping a patient
Permissively hypertensive.
Yeah, hypertensive. So it's really just giving them a little bit of something to meet that guideline that we need.
We're not, we don't, it's actually counterproductive in stroke to drop the pressure too low. We want to permit some degree of hypertension, but as Natalie said, we just want to meet the thresholds to make the alteplase safer and decrease the risk of hemorrhage.
Yeah, and I'm directing the team. One of the cases, so for example, in this case, what I'm doing is I know that initial blood pressure in the hallway. And so I'm actually telling my nurses, because I can't do this without the buy-in of the nurses and the rest of the team, I'm actually telling them to bring me labetalol or hydralazine to the scanner. And so before I even have a plain head CT, that labetalol or hydralazine is on board. So now when we recycle it at least 2 more times, we know that we're still going down the right pathway.
Yep.
So I can't remember if this gentleman got labetalol or hydralazine, but I usually go with labetalol because I do find that it's the quickest acting as long as their heart rate can take it.
Yeah.
That's how I determine. You know, if somebody's heart rate is 45, I'm not going to give labetalol, I'm going to give hydralazine in that instance. So his blood pressure is now 162 over 96, and the question would be, does he now have any contraindications to IV alteplase?
No, I mean, we now have a head CT, it's negative, there's no evidence of hemorrhage. I say, let her rip.
Yes, so, you know, go or no-go decision here. And I made the decision to go ahead and give the alteplase. His blood pressure was controlled now. He could answer yes or no at least. So when I asked him questions, do you have a history of stroke? Are you on any of these medications, Coumadin, Pradaxa, Eliquis, Xarelto? You know, he could at least say no. And not only did he get IV alteplase, he actually got a thrombectomy with Dr. Liebman. And he did great. I think that he was actually discharged to home 2 days later for some speech therapy.
Yeah. That's great that you were able to see a response from him almost right away. I think that that's something that we almost shortchange ER practitioners about, because not all patients have that response. Sometimes it does take that 24 hours for the patient to or longer to recover, and it's always good to go back to the ER practitioners that were taking care of the patients and say, you know, what you did, it actually worked.
Exactly.
And especially nursing staff that they say, I always get questioned, you know, oh, we gave tPA to that patient.
How'd they do?
Yeah, how'd they do? So.
And I think that's a really important point, because we used to wait until the tPA alteplase infusion had completed before we made the decision to go to thrombectomy. We haven't done that for years now, because the randomized trials have proven that thrombectomy plus alteplase is superior to alteplase or tPA alone. So that's a good point. We don't wait to see if the patient improves anymore. We just whisk them off to the cath lab.
Yes. So then we put in some other hypertension scenarios. As we were putting this talk together for you guys today, it's interesting that we've been taking care of stroke patients forever, and we still have the high blood pressure battle for the different scenarios.
Yeah.
Should we be lowering it at all? If we are going to lower it, what is our target? And even as we sit before you guys today, we don't have great answers, but we'll kind of give you what our daily practice is. So that CAT scan does not belong with this case quite yet.
No, this is a different patient
Yeah.
who presented with a hypertensive hemorrhage. And there was just, since we're on blood pressure control, it's a discussion of the difference between ischemic and hemorrhagic stroke and blood pressure management. So this patient presents in hypertensive crisis with a hypertensive hemorrhage with a blood pressure of 225 over 125.
Actually, if you click one more, so that's that case on the right there.
Oh, okay.
Yeah. So the first scenario that we want to talk about is more the norm of what we see. An 81-year-old male, right-sided weakness, dysarthria, aphasia. It's been going on for 2 days. So he's not an alteplase candidate. His CT head shows a lacunar infarct. So the timeline's right. He's been having symptoms for 2 days. And his blood pressure is 225 over 125. And this is one of the cases where we really want to let somebody be more hypertensive to perfuse their brain. His MAP is 158. And this is where people run into a lot of barriers, I think. You know, I know as an ER doctor that we want to let him be 225 over 125, but maybe the hospitalist doesn't want to accept them on their service because that blood pressure freaks everybody out.
And I just want to clarify, I'm sorry I caused confusion, but the 81-year-old patient does not have a CAT scan. We just are telling you there's a lacunar infarct. So that's a patient we want to allow to be permissively hypertensive for 24, 48 hours and then slowly lower the blood pressure. Lacunar infarcts tend to be from small perforating vessels, and they are very well known to fluctuate, be what we call MAP dependent or dependent on the mean arterial pressure. So we want to minimize that fluctuation, try to keep those small vessels open, and that's why we do that.
Yeah, and I think, you know, American Heart, American Stroke says that if your blood pressure is greater than 220 over 120, that it might be safe to lower it about 15%.
Right.
If I called you with this patient from the ER, what do you think you would tell me about his blood pressure?
I would say you can very gently lower it.
Perfect.
Exactly what you just said.
So that's where the lower doses of your IV push medications come in.
Maybe
so
5 of labetalol.
Exactly.
We're 2.5 hydralazine.
Yes, very gentle. You know, if he's on the floor, we're not starting with 10 of amlodipine right away. We're going very baby doses, 2.5 to see how he responds, and then going.
We're not bringing this patient to the ICU for a nicardipine drip because that's really not in this patient's best interest to rapidly lower the pressure. So.
Yeah, and then I think that's where a lot of the controversy is more with these ischemic stroke patients and the high blood pressure. I feel like the hemorrhagic stroke that we're showing you on the right side here, the 70-year-old female, left hemiparesis, rightward gaze, unresponsive, blood pressure 199 over 117. You know, we thought that we knew that we should be aggressively lowering blood pressure in these patients, but there's even controversy about that now too. And so maybe you can talk about some of your targets for these patients. So
we originally had an AHA guideline of getting the systolic blood pressure 140 or less. But I think the realization is that these patients are chronically hypertensive. So their end organs are dependent on a certain blood pressure. And so you drop the blood pressure too severely in a patient who's chronically hypertensive, you might end up with acute kidney injury, you might end up with a hit to the liver, and also their brain is autoregulated in a way that we want to promote perfusion with a large hemorrhage, and we suspect that there's increased intracranial pressure. So I think we're shooting more in the 140 to 180 systolic range for these patients nowadays. A lot of times we'll try to give nursing a mean arterial pressure goal. It gives them more of a range that we look at both systolic blood pressure as well as the mean arterial pressure goal, but sometimes in the ICU it's easier to achieve that target. So.
Yeah. And again, did you just want to review the same drugs?
Right, so it's going to be the same medications for intracranial bleed, hypertensive bleeds as it is for ischemic bleeds. So we're going to be doing our labetalol pushes and then going most likely in these cases faster to either a nicardipine or a clovidipine drip. And I don't know how you guys have felt lately, but I feel like we're moving more towards clovidipine over nicardipine. just because of the sheer volume of nicardipine that we have to infuse, to me, is almost counterintuitive.
It is. You have these hypertensive patients and you're fluid overloading them.
Yes, exactly. So at
Yeah.
least with clofidipine, it's a small amount. So unless they have any kind of soybean allergy or egg allergy, or because it's in a lipid emulsion, I think it's just a better agent to go with.
And then post-op, so this is a fatal hemorrhage unless it's evacuated in the operating room. We're also very concerned about blood pressure management post-operatively. So once the hemorrhage is evacuated, we want to prevent reaccumulation of the hemorrhage. So we're using the same blood pressure guide post-op.
Are there any questions about hypertension yet, or we'll keep going? Okay. Yeah, so that's kind of the neat thing about stroke is one of the diseases that's just ever changing, and we still don't have concrete answers.
Right.
So we're going to move on to another possible complication or interaction. This is a 64-year-old male, presents with left-sided facial droop, left hemiplegia, slurred speech. His NIH stroke score is a 12. That's actually a pretty high stroke score for somebody who's having a right hemispheric stroke, because he's not really getting points for language. He's getting points for neglect and things like that.
Sorry about that.
That's okay.
Oh, okay. Very good.
So he actually is going to be the drip and ship model that we have at GNI. He gets alteplase at a spoke hospital and then is transported to us, to our hub hospital at Crozier. His exam initially improved, but then he started vomiting and complaining of a headache. So we repeat a head CT. And this is what the repeat head CT looks like. And for all of the emergency providers out there, so this is the quote unquote dreaded complication that we fear. And if you look at this CAT scan though, this bleed is small.
It is, and that's why I specifically wanted to present this case, because I think the fear is that 2 to 6%, or whatever the real number is, of alteplase hemorrhages, the fear is that they're all fatal and there's nothing you can do about it. But that's actually not the case. That's actually the minority of cases have fatal, fatal hemorrhages that we can do nothing about. This is what we typically see.
Yeah, and I think that's reassuring to know that if a patient's going to bleed, that it's going to look something more like this than the devastating hemorrhage that we worry about. So from an ER perspective, things that I'm going to do if they do have this conversion, we're going to do seizure prophylaxis. We're going to intubate the patient if needed. We're going to do blood pressure control with everything we just talked about. But most importantly, we're going to do our reversal protocol.
Right, and that's something that we institute for patients that have any kind of symptomatic bleeding after alteplase. And I think that that's also a distinction that we need to make, symptomatic versus asymptomatic.
Right.
How many microhemorrhages do we pick up on the 24-hour CAT scan that really just nobody would know if they existed if we didn't CAT scan the patient?
I think that time frame is also very important, because when we talk about tPA hemorrhages, we're talking about acutely, like while it's being infused, or within an hour or two of that, the patient gets a headache and you scan them. If you're talking about 24 hours out, the alteplase is already out of your system. The half-life is actually quite short. So this reversal protocol, you wouldn't do it for a hemorrhage that you notice 24 hours out. It's already out of the system. But in this patient's case, the alteplase was still hanging. So we stopped the infusion and then institute the protocol.
Right, and then with the reversal protocol, we say reversal because I think that's very easy to say, but it's not really reversing the tPA.
Exactly.
We're giving fibrinogen, which is what, if we remember, alteplase is a fibrinolytic.
Yep.
So it stops the fibrin from turning into fibrinogen. So we just give back the fibrinogen so that the patient's clotting begins to act normally again, since that's the pathway that was broken down. And what we do is we give cryoprecipitate along with platelets. In our hub and spoke model, I think we sometimes take for granted that we, in our hubs, have cryoprecipitate available very readily. There's many institutions, so unless it's a trauma center, unless it's, you know, somebody that has a NICU, a neonatal ICU, they don't really stock cryoprecipitate. And that's a question that we get asked a lot. I mean, should we start stocking it? And we always say no, because
it's so rare.
It's so rare. I mean, the alternate for that is actually tranexamic acid. And so if you can't get cryoprecipitate, if your blood bank says it's going to take, you know, 2 hours to get delivered and then it has to get thawed, the best thing to do is to give them some tranexamic acid, and then we would ship them to our hub. We would recheck a fibrinogen level again, and at that point, if we needed to, we may give some cryoprecipitate, but again, it may not be necessary depending on the patient's status and how they're doing.
And, you know, it kind of goes along with something that we're doing at Crozier for our alteplase patients who don't have a hemorrhage. You know, nationally, these patients are staying in bed 24 hours before they can work with therapy, before you can start, you know, maybe aspirin on them. But we're using fibrinogen as a marker for, is it safe to actually start anticoagulation? Is the alteplase out of their system so it's okay for them to get out of bed? So really the fibrinogen is what we're looking for, to be corrected to know that the alteplase is no longer a threat.
Yeah, and the other thing that we had talked about is cryoprecipitate and platelets both do not have to be type and cross-matched.
Right.
So it's something that should be able to come up from the blood bank and be able to start it, you know, relatively immediately to best help these patients that are having a hemorrhagic conversion.
Good point, because, you know, a lot of times if you're waiting for your type and screen or type and cross, that can take over an hour for most blood banks. But with a physician's signature, you say, I need uncross-matched platelets, it's an emergent situation, and the blood bank will do that. So.
Yes. So I think we know that this is the dreaded complication. It happens about 2 to 3% of the time, even though we're still obligated to quote the 6%. But we do have ways of reversing it. And in this particular patient, not only did we reverse him, but he ended up getting discharged to subacute rehab.
He did. He did.
Yeah. So not nursing home bound, not a trach and peg for life.
Exactly.
You know, discharged to subacute rehab.
Nor was it a fatal bleed. That's the other. Yeah.
So, you know, maybe he didn't have the benefit of his stroke symptoms improving, but he also, in the end, he wasn't harmed by the alteplase.
Yes.
This is really the rare devastating case of a tPA hemorrhage. As we mentioned, we hardly ever see this. This is maybe a once or twice a year phenomenon, and that's pretty small considering all of the patients who we administer alteplase to.
Yeah, this case happened almost exactly a year ago. This was another drip and ship case from DCMH to Crozier. This was my case with Dr. Vez, and he was confused why he was hearing from me. He said the patient was supposed to go straight to CAT scan, and I said, no, the patient decompensated en route, and this is one of the bigger bleeds that probably we've ever seen. Which is unfortunate, but that also leads to the conversation, who are the stroke patients that bleed? The stroke patients that bleed are the ones that are actually having a stroke.
Exactly.
Okay, so if you do give alteplase to a stroke mimic, you give it to a Todd's paralysis, or you give it to a complex migraine, or my favorite, the conversion disorder.
Yeah.
You know, the vascular brain is normal.
Exactly.
And those patients will do well.
So your chance of having a hemorrhage from the alteplase is not zero, but close to. So that's a good point.
Yeah, and I like to use the analogy that, you know, back in the day, and I'm dating myself here a little bit, but when I was a resident, we actually gave Redivase or TNK to heart attack patients. And we never consented them that you might bleed in your brain from this.
Really?
That never even came up because your brain was normal. The problem was somewhere else.
Good point, yeah.
So I think that's just an interesting point to point out.
Right,
as
but
well.
remember, all of these fibrinolytics, they look for the fibrin clot in the body, and that's where they go. So if there is no clot anywhere, so if your suspicion for stroke is actually low, it goes for normal tissue.
Yeah.
Right. And I think that should empower ER providers to feel more comfortable pulling the trigger on treating the next patient that's in front of you, even if maybe you're not sure.
Exactly. I think if anything comes of this talk, it's that for the most part, alteplase is safe for stroke.
Absolutely.
Yeah.
So case number 3 was another case that every time I think things can't get more complicated, they do. So this is a 57-year-old female who went to take a nap at 11 a.m., woke at 12:30 p.m. with left-sided weakness to her arm and her leg. And she had had a laparoscopic nephrectomy 2 days ago at a different hospital. And they had stopped her clopidogrel, her Plavix, for the procedure. So of course it had to be in another facility, and I didn't even know you could get discharged home 2 days after having a laparoscopic nephrectomy. It sounds like a pretty big procedure to have. And then, just for extra fun, she says that she's anaphylactic to IV dye, which when you tease it out with her is hives and trouble breathing, but did not require intubation.
Okay.
She has the risk factors. She's diabetic, she's got coronary artery disease, she's a smoker. Her vital signs look pretty stable, and you know that she's having a stroke, right? She stopped her Plavix to have another life-saving procedure, but there's a lot of things that we have to work through here, and the dye allergy is something that comes up more frequently than I would like. So we're still going down the pathway as if she's possibly a candidate. Luckily, she's got the weight greater than 100 kilos. Again, I like that. The Acute is fine. And for her neuro exam, so she's got some weakness on the left, the face, the arm, the leg. Her gaze is normal. She's a little ataxic on that left side. Her stroke scale is a 7, and her head CT looks good. So the question is now, and I think I'm hitting all 4 neurosurgeons in the talk here. This is my case with Dr. Hochma. Call Dr. Hochma and say, you know, I'm not really sure that she's a candidate for IV alteplase with a because it's laparoscopic, right? It's not open, but removing a kidney is kind of leaving a big space in your retroperitoneum there that could potentially give you a big area to bleed into. So we're in agreement that we're not going to give her alteplase. But the next question is can she get IV dye? And I really had to tease out some more information as to what her allergy was. She's actually a former nurse at our facility. And we basically had a risk-benefit discussion. I remember talking with Zach and saying, should I just put her in the MRI machine? And he said, well, if you put her in the MRI machine, I'm not going to know if there's penumbra to do an intervention. And so we had a risk-benefit discussion with her, and she agreed that we should do our rapid prep to see, she's not an alteplase candidate, is there an intervention that we can do? So our rapid prep is 10 of Decadron, 50 of Benadryl, 20 of Pepsid, and that does come from some literature in radiology.
Yeah, I mean, radiology literature, unfortunately, is very scarce when it comes to any kind of
we looked
for it. And so, you know, they, I think, maybe do like an 18 or 17 hour prep with just prednisone, but we try and also do, maybe there's a histamine component to it. Maybe we can block that with the Benadryl and the Pepsid. So that's where we try and make sure that, and then obviously the steroid with the swelling. What's interesting about her case is that she said she had an anaphylactic reaction that did not need intubation, which, you know, if somebody has an anaphylactic reaction, a lot of times those patients, you know, they do need intubation. So was she having trouble breathing because of
Was it really angioedema?
Right, exactly. Was it angioedema? Was it hives and she was just itchy, and then she developed, you know, anxiety from the event? There's a lot to tease out here about why she can't get the IV dye, and it may not be that she's allergic.
The way I think about it is it really a histamine reaction, like you were saying? Is it more hives and itching and redness? In those cases, I think the rapid prep is safe. If it really is anaphylaxis with angioedema, airway edema, I would not do the I would not do the rapid prep and give the IV dye in those cases because it's really not a histamine reaction,
Right.
and I would worry about having an airway issue in CT. In those cases, we probably would get the stat MRI, and what we would look for is the diffusion mismatch with the T2,
Flare
and
and
we
flare.
would, as a surrogate, we would sort of use that mismatch as penumbra if we could not get the CTA.
Yeah, I
So-
guess we could also use an aspect score too.
You could definitely use aspect score with
Yeah.
just on a plain CAT scan.
And you bringing up the point of whether it's a histamine reaction or if it's any other kind of angioedema, we have to make the same decision with tPA.
Yep.
A lot of times, it's not very common, but patients can develop allergies to tPA. So at that point, we also have to not only stop the tPA infusion because they're developing angioedema, but we also have to either treat them or we have to do an emergent intubation while they're bleeding risk. And what we find out is a lot of times when patients develop angioedema because of tPA, it's not a histamine reaction. It's actually the kallikrein cascade. So that's where, giving platelets or giving a C1 esterase inhibitor, almost if you've ever treated a patient that has familial hereditary angioedema, the bare inert patients, those
Yeah.
are the ones that they come in, they look exactly the same as your tPA
Exactly.
patients, and that's where you would treat those types of patients
Differently,
And,
yeah.
exactly.
And so I think it's an important distinction. In this case, as you can see by this slide, the patient, I think it was determined it was mostly hives and maybe a scratchy throat, and so did get the rapid prep and got a CT perfusion safely.
Right. Yeah. And I mean, everything's about shared decision making too.
Yeah.
We're not on islands by ourselves. We can have an educated discussion with this healthcare provider. And it was actually fortunate that we did, because if you look at the mean transit time there,
Sorry.
so the whole right hemisphere there, that red, so she's got increased mean transit time to that whole hemisphere, and she actually has a huge mismatch between her blood flow and blood volume. So the dark blue on the blood flow there on the right hemisphere, but if you look at the blood volume, that's pretty symmetrical. And what it turned out is that she had a blockage in her carotid, and she ended up at least being able to go to the intervention
I was gonna
suite.
say, yeah, this looks like a carotid occlusion just because of the hyperemia or the oligemia that you can see. And then this is just the protocol that we use for angioedema reversal. I don't know if there's anything else you want to say about it, Natalie?
We touched upon it briefly, but we do the methylprednisolone, the diphenhydramine, the famotidine, and I think as healthcare practitioners, we have to do something if we have a patient
Right.
that has any kind of allergic reactions. We're like, all right, we're going to give them Benadryl, we're going to do the Pepcid.
I think stopping the medication is the first thing.
Exactly,
we can do, but-
yeah, that is the first thing. But in terms of discontinuing anything, or in terms of starting anything, that's what we do. But oftentimes with alteplase angioedema or alteplase allergies, it's self-limiting. So in 24 hours, you'll find that the patient goes back to normal because, again, alteplase half-life is very short, so they're not going to need a lot. Some patients do need to be intubated, and we do recommend intubation in those patients earlier rather than later because it could be a little bit of a traumatic intubation.
Yeah.
But
Sure.
other than that, they're very much self-limiting.
A common question that I get from ED providers is, why is epinephrine not part of our pathway?
Well, because again, there's no good reason for it. It's the same reason of why Salumedrol, Benadryl, and Pepcid also really shouldn't be part of the pathway. That's not the mechanism of the allergy. We do it almost to make ourselves feel better more than anything else. I think epinephrine gives that little bit of something extra if the patient's allergy or angioedema starts to progress even worse, which is very uncommon. And I think this recommendation is a very low level recommendation if you look at the guidelines. So it's almost of expert opinion of what could be what you could do or what's in your bag of tricks.
Right.
I think almost every paper that we've pulled has said just time is really the key for
and
this.
I think of epinephrine as something you do if the patient's going into shock, you know, and they're being monitored in the ER. We're not going to let it get to that point.
Exactly.
So.
Yeah, and I know I would have anxiety about giving a stroke patient epinephrine and making their blood pressure now go to 250
Right,
over
exactly.
200. And I think that just the last point before we get to some of your thrombectomy complications is this is sometimes really hard to vet out. Is it the alteplase or is it the IV dye?
Yeah.
So the case that we had together just last week, as we're putting this talk together for you guys, I'm texting these guys after hours. So we had a lady come in, number one, hypertensive. So we had to treat her blood pressure to get her the IV alteplase. But what happens is these patients get IV dye for a CT perfusion and a CTA. And about 2 hours after the alteplase infusion, she started to develop a rash. She started vomiting. And she actually started to become hypertensive.
It's like the telltale signs of tPA bleed.
Yeah.
Yes.
Yeah.
So Dr. Naden, who's moderating, we actually did send her down for a repeat head CT, and at least it wasn't the intracranial hemorrhage. And it's not a big deal, is it the alteplase or the IV dye in the moment, because the treatment's the same.
It is.
The steroids, the Benadryl, the Pepsid.
In that patient, we really didn't know. It was, we went by process of elimination. She got the contrast in one arm and the alteplase in the other, and we went with the arm that had the rash. So,
Very scientific.
Yeah, very scientific. So.
Yeah, and I think just the other thing that we didn't mention is the people who are predisposed to these reactions are the patients who are on ACE inhibitors or angiotensin receptor blockers, the ARBs, or the unfortunate stroke patients that have been exposed to tPA at some time in their past.
They've been sensitized.
And the biggest thing with the case last Wednesday was, are we now going to label her as a dye allergy moving forward? Because that's important to
Which we did.
To know.
We did, just because what's the downside of giving her a prep if she needs it again?
Right.
So that's what we did.
Right. And she had actually received IV dye in May for CTA of her chest that apparently she did fine with.
Yeah.
So just lucky
But
me.
again, that's
She may have been sensitized,
Yeah, that's
yeah.
what happens with allergies is just the sensitization occurs, and the next time it could be
Exactly.
even worse.
Yeah.
So while we're on the topic of dye, interesting discussion that can be posed to anybody in terms of dye and kidney patients. What do you prioritize, and how would you manage such a patient in an acute setting?
Brain wins
Brain
at all
always
times.
wins. Yes, definitely.
Brain cannot be replaced. For kidneys, we have dialysis.
Yes.
And to be honest, I think the concern or the fear of acute kidney injury with IV contrast is overstated significantly as well. It's something that we rarely see. That's another one of those once or twice a year things, and we're not going to risk the brain for a 1 to 2% chance of acute kidney injury.
Well, especially because we have ways to flush out the dyes. So we're we give patients adequate hydration. We're no longer, keeping their fluids at 40 during that period of time.
Right.
We'll run it a little bit higher. We make sure that they're not on any other nephrotoxic medications.
We hold their metformin.
Exactly. So we're more aware of it. And I think the more and more we're aware of complications, the less they become common.
Exactly.
Yeah, and actually that's a really good point too, knock on wood on our table here. Of all of these rapid preps that I've done for CTP, CTA, I haven't seen
and I think it's patient selection.
Right.
Yeah.
Yes. That's a good question though, and I think the GNI mantra is there's a lot of organs that can be transplanted, and the brain, but the brain is pretty much the only one that can't.
Yeah.
And we're gonna sacrifice the kidneys in the short term to save the brain.
But the risk, and we're not trying to sound cavalier, because that risk is actually quite small. So.
Right, especially with things like Visipake now.
Exactly.
And like you mentioned, just staying on top of it, aggressive hydration, and just recognizing it.
Okay, so let's get to our last case. This is a 76-year-old who presented with right hemiplegia and aphasia, was out of the window for alteplase. This is our CT perfusion scan, and I think the thing to notice is that the scan on the left looks pretty symmetric, with just maybe a little bit of extra blue in the left hemisphere. The scan on the right is the much darker blue. That mismatches how we determine penumbra. So this is somebody who is a thrombectomy candidate. So at the time of thrombectomy, there was a carotid occlusion from a severe calcified stenosis. So in order to even get the catheters up to the brain, that required a emergency angioplasty and stenting, followed by emergent thrombectomy. You can see the image on the left. The MCA is occluded at its mid portion. All the way to the right, you can see the MCA has been opened and the carotid has been opened as well. So it's what we call TICI-3. It's actually a revascularization score that we stole from cardiology. But TICI-3 means we have full revascularization. The patient actually did very well neurologically after the procedure. Speech improved, strength on the right side of the body improved. And you can see that scan in the middle, that's what we call diffusion MRI. You just see two little tiny dots of stroke, where on that perfusion scan, had the patient not undergone thrombectomy, you would have expected the entire MCA distribution to be infarcted. But what we saw in the GRE sequence is there is some blood in the subarachnoid space. Now, when I see that, I go back to the angiogram and I say, was there extravasation of the vessel that I didn't recognize at the time of the thrombectomy? Because subarachnoid means the blood got out of the blood vessel. And there was no extravasation. Everything was fine on the angiogram, but I think these vessels are just fragile and friable, so you can get leakage of not only contrast, but a little bit of blood without having a full-blown rupture. This is a very small subarachnoid hemorrhage that will completely resolve, and the patient will have no effects from this. We do give I would do a week of Keppra just because not only the contrast, but the blood can be irritating. But we get a stable follow-up head CT, and then we treat the patient just like the blood was never there. So.
Yeah, and I think just to clarify for some lay people that are out there, so the images that you're looking on the left and in the middle are the MRI images. So the one on the left, we're always taught in the ER that blood is white.
On CAT scan.
So the CAT scan image is the one on the right, and that's where you're seeing blood is white. Mm-hmm. The one on the left, on MRI, blood is actually dark or black.
Yeah.
And then the one in the middle is the DWI images there, or did you say GRE?
No, that's a DWI.
That's the DWI, right? With the small ischemic infarcts.
Yeah, and on the CAT scan on the right, you can see that the blood is almost as bright as bone, which blood is usually less bright than bone. So that's why I'm saying there's contrast in there, because the contrast is super bright. So so this is not what we would call hemorrhagic transformation of a stroke, which we see commonly actually. We see hemorrhagic transformation of stroke, whether we do thrombectomy, whether we do alteplase, or whether we do nothing. It's very common for strokes to have hemorrhagic transformation. This is actually a case where I think because of the thrombectomy, removing the clot and just the friable vessel, there was a little bit of leakage. So what this is in case 1 is actually a 32-year-old who had a left ICA thrombectomy, and this is what we call a type 1 hemorrhage. Type 1 means that you see a little bit of bright blood on the CAT scan within the infarcted brain. It didn't change the patient's NIH score. It's, there's symptomatic ICH, as you were saying, Natalie, and then there's just these hemorrhages that you incidentally find because that brain is, you have bleeding into infarcted brain, and that is not something that is clinically significant or that you would even know when examining the patient unless you had a CAT scan. The patient in number 2, though, is someone who actually does have a clinically significant hemorrhage. The NIH changed, so the patient had imaging. And this is a clot that would require surgical evacuation because it's in the posterior fossa and is causing mass effect. So that is also exceedingly rare. Certainly less than 1% of cases do we get symptomatic ICH.
And I think that's a good point. We define symptomatic ICH as an increase in 4 points on your NIH stroke scale, not just a little ditzel of blood like in image number 1 that you had shown on that slide. Yeah. And then your second case, if you have a basilar artery occlusion, that's devastating, locked in.
Yep.
You know, we need your magic hands to try to make it as best outcome as possible. And if it turns out that they do have a complication, then you guys will
We
keep going down
fix
the
it, yeah.
pathway.
Yep.
Yes.
Can you just go over the differences between like a TICI 2B and a TICI 3?
Sure. So, TICI 2s fall in the category of partial revascularization. So, TICI 2A is you get it open, but the blood flow to the territory, it's not really getting there. The vessel looks open, but there's stagnation of blood flow. TICI 2B, there's blood getting to the say it's the MCA distribution or the MCA territory, but maybe there's like a little thrombus there, just a little bit of stagnation, but for the most part you can tell that the brain is perfusing. That's a 2B. TICI 3 is normal perfusion of the brain.
Yeah. Which you guys are pretty successful at getting most of the time.
So we can get the artery open most of the time. I would say over 90% of the time. If you look at the randomized trials, revascularization 2B or higher is over 90%. I would say it, in our hands it's certainly over 95%. How that equates to an improvement in the stroke scale, or what we look at modified Rankin score, about 50 to 55% of patients are going to have functional independence if we can get the vessel open.
Yeah. Which is great.
Yep.
Which is great. So it looks like they have a couple questions for us up there.
Yeah,
Do
I
you
think
wanna
we're
take
ready
the,
for questions. That's
How much cryo for reversal?
Yeah, so cryo for reversal, if you guys go back to your slide deck, we actually listed it out where cryo is going to be 10 units, and you want to give that with 6 to 8 units of platelets. So it's pretty easy to remember because it's always going to be 10 units of cryoprecipitate.
Is it a 6-pack of platelets or a unit of platelets, which is a 6-pack?
It is a unit of platelets, which is a 6-pack.
We always get that
I know
question.
it is.
Yeah.
It's always so confusing, and the blood bank changes its naming constantly,
Exactly.
so can't keep up. Something else I want to point out is that we would redose or consider redosing if the fibrinogen is less than 150, which is actually new. It used to be 150, and then they changed it to 200
That's right,
of fibrinogen. And then I think that was one of the only changes in the guidelines, again, where they changed it to 150 again. So it's like they're making sure if we're reading them fully or not. So we had to change that one piece from 150 to 200 to 150 again.
And I don't know what that's based on, to be honest. I think in most labs, a normal fibrinogen level is over 200, just in the, anybody walking around. But I think the bleeding risk is actually only there if it's less than 150.
Exactly.
So I think that's why they went back to 150.
And we've actually seen that ourselves, where if patients have a fibrinogen that's less than 150, we almost watch them a little bit closer to make sure they're not going to bleed, because those are the ones that tend to have either a hemorrhagic transformation or some kind of bleeding somewhere.
Agree.
And these protocols, for the audience that's out there virtually, we can, these are all of our protocols that are published and vetted, and we can share them easily. The new info guidance of new AHA info, that could be a lot of different things that I can think of.
Was it specific to something, the new?
That was a general question. People just were inquiring if there's any new guidance on the AHA recently.
Not really. I mean, the stroke guidelines haven't really been updated since 2019. There's new target stroke guidelines in terms, and I don't know if that's what they're referring to, but in terms of timing for alteplase, maybe you want to talk about that, Karen? The new target stroke guidelines?
Yeah, I could talk about door to needle, and you can talk about door to device. So it was interesting in 2019, so about a year and a half ago, we always knew that American Heart and American Stroke was going to throw down on us for faster door to needle times instead of 60 minutes to target 45, because whether you're a provider out there that believes in alteplase or not, there's no doubt that the faster you treat a patient, the better the outcome. we have very good data about that. So where the guidelines are at now is they actually threw down on us a door to needle time of 30 minutes in those target stroke phase 3 guidelines.
Right.
And you want to be getting door to needle times of less than 30 minutes in 50% of your patients, 45 minutes 75% of the time, and 60 minutes 85% of the time.
Yep.
So we always knew the 45 minutes was coming.
Yes.
The 30 minutes kind of caught us off guard. In the neuro ED, we do really take a lot of pride that me and my team, we are consistently getting door to needle times less than 30 minutes. And that's thanks to the medics and thanks to our EMTs and thanks to our nurses who totally buy into what we're doing, because it's not easy to do.
Yeah, I think even things just as simple as, anybody can call a stroke alert, whether it's the person in triage or the nurse who's getting the patient out of triage. So you don't have to wait for the ED physician to see the patient
Yes.
call a stroke alert. And I think that has made a huge difference.
Yes.
Well,
and
stroke education in general has made a
It
huge
has.
difference. I think stroke education is now where probably
Cardiac.
cardiac
Yeah.
education was 20
We're
years
always
ago.
about 15, 20
yeah,
years.
exactly. I mean, everybody got education. If you've got arm weakness and chest pain, you're having a heart attack. We teach stroke education to school children the same way now.
Yeah.
Is if somebody has a droop or slurred speech, they're having a
Yeah.
stroke, call 911. So same exact thing. So we are behind a little bit, but the more and more people know, the better it's getting, and that's why I think the AHA is saying that we need to get on top of this and get our times down.
Yeah.
Yeah, and so Target Stroke Phase 3 actually introduced the first door-to-device times ever also.
So what we're looking for in that are patients who present to our own emergency department. They want us to, from the time they enter the door to the time that we actually do the first pass, 90 minutes.
Yeah.
And for patients who are transferred in, that time is 60 minutes. And you might say, well, that seems counterintuitive. It seems like if the patient's already in your hospital, it should be the shorter time frame. But the thing is that if I'm getting a call from an outside hospital, I know the patient has a large vessel occlusion because they already had their workup at the outside hospital, CTA was done. There's that transport time where you have the luxury of calling the team in. We have to be in the hospital 30 minutes from time of phone call. So we can basically be there waiting for the patient and pounce on them as soon as they arrive, and we can usually achieve that 60 minutes. The thing about the patient who comes in,
Yes.
through the door, who walks in, you don't know they're having a stroke. Like the phone call I get that says, yeah, I have a patient who's having a stroke, and then I say, fly him in. Well, the patient who walks through the door, you still have all that workup to do. And so that's where you get the extra 30 minutes to figure out what's going on with them.
Yeah, and if you think about it, where did target stroke come from? Target stroke came from 50% of hospitals across the country can't even meet a door-to-needle time of 60 minutes. So how are you going to meet your door-to-device time of 90?
Exactly.
And I think it's important to note that it's not door to groin.
No,
It's
first
door
pass.
to device deployment.
Yep.
Dr. Binning, Dr. Vez, Dr. Lehman, Dr. Hakma, they're not stopping at the heart, right? They're going through the aortic arch, up your carotids into your brain with what they do. So there's extra time just to navigate that.
Or like the case that I showed, I had to actually revascularize the carotid before I could even get up to the head. So all of that takes time. It's, the clock is ticking.
And the only other thing that I would mention about American Heart, because I think it fits our panel beautifully, is with the new info and guidance is their recognition of tenecteplase.
Yep.
And how I think that we'll really see that take off. Tenecteplase is another fibrinolytic that's a one-time bolus, which would really make drip and ship a lot easier. I'll let you talk about the pharmacokinetics. Right now, why we're not using it is because it's not FDA approved for stroke, but American Heart actually did update their guidelines to say that they
That it's
recognize
acceptable,
it
yep.
as a lytic, and maybe you
Yeah.
can talk about some of the
I
advantages.
mean, all of the so the studies were actually done in Australia. Yeah,
We're
for
better.
for tenecteplase, we tried to do them, and we I think we got turned down or something,
Yeah.
or the Joint Commission said we couldn't.
The
use,
Joint Commission
yes,
wouldn't recognize
yes.
it at that time, but they've since changed it.
Exactly. We were ahead of the game, but
Exactly.
trying to be.
but
Yeah.
it's a more specific fibrinolytic, which is great for us from a stroke perspective, because as you guys remember, we talked about that the fibrinolytic looks for the fibrin clot. And so there's minimal calculation. You don't need to remember 10% of the bolus, then 90% of the infusion. You just give it a push, and then you can ship them wherever they need to go, which is, I think, a little bit easier for all parties involved.
And I think while we just have a few more seconds, I do want to say that we are giving alteplase in the 9-hour window, which has already been vetted out in the Extend trial. But we have the imaging to ensure that we can give it safely in that extended 9-hour window. So we're really doing everything. It's safe. It's been proven, but we're ahead of the curve in terms of the AHA guidelines for sure.
I think that's actually a really good place to stop, and we can segue into that with the neuro ED and command center talk.
Yeah.
Bye. Thanks, guys.
Bye.